Welcome to CLL Support's webinar, Getting the Most Out of Consultations. I'd like to draw your attention to the fact that we're indebted to the following pharmaceutical companies for the financial support they have provided towards the cost of these CLL Support webinars. They, however, have had no input to the content of the program or the choice of speakers. So today's panel, we have three clinicians and myself. I'll act as host and also the voice of the patient, so to speak. We have Professor David Alsop from York, and also Dr. Andres Frieger, who we met back last year when we had our conference in York. And we also have Deborah Reed, who we'll probably refer to as Debs for the rest of the webinar. And Debs is a CNS working with David and Andres. I appreciate the time given by our three clinician speakers because they are very busy people. In fact, if I remember back for the York conference, Andres actually came in on a day of his annual leave to speak to us. So that just shows their commitment, and we certainly appreciate that. The format of today's webinar will be in three distinct parts. We'll talk about the initial consultation. We'll then move on and we'll talk about active monitoring. And then we'll move on to approaching treatment. And the reason for breaking it into those three component parts is that we can concentrate on the specifics and the nuances around the conversations and consultation content that we would have at that time. You'll see the picture on the left shows a typical cartoon, so to speak, of a consultation. The clinician is clearly identified in her white coat, and we have a patient and their partner or a trusted confidant. That's a clip taken from our Milo's video that we have on our website, and the little sort of cartoon character in between the two people is Milo. So this is the typical setup of a consultation, and we'll talk about the importance of a partner and the role a partner will play in consultations. So I have a few images here just to sort of form up and shape the conversation that we're going to have. The first one is not megaphone diplomacy, but it is pretty much, let me explain. And the let me explain could be the clinician talking to the patient and explaining all about their diagnosis. We appreciate that to a certain extent, this might be talking about the consultation at a diagnosis might be a little bit false by virtue of the fact that it's only after your diagnosis, which probably is delivered by a consultant, that you will then have all your questions. So talking about how to prepare for and get the benefit from the initial consultation is a little bit false, but we do know a number of our members have actually had their diagnosis delivered by a GP, and then sometime later, hopefully not too long later, they have their formal first consultation with a consultant hematologist. So there's also an explanation coming from the patient to explain their background and their circumstances. There will be laboratory tests, and we'll talk about the sequencing of blood tests, FISH, and scans, and any other tests like bone marrow, for instance. And there will be a listening phase. And the listening phase is both ways. It's the clinicians listening to the patient's concerns, and it's the patient and their partner listening to all the information that the consultant or clinical nurse specialist will be imparting to them. And of course, time. So time has a couple of different aspects here. The time allotted to a consultation, it's busy clinics. Those of us who've been there will know only too well. is short. So we need to try and maximize the effectiveness of the time that's allocated. One of the skills of the consultants is to be able to put us at rest and try and manage the time effectively for us. But we can effectively manage our time by having a certain level of knowledge gained from responsible sources like our website, like our booklet, and having some questions ready. Time between consultations, time from when you've had the initial blood test that paved the way towards getting to the point of the reveal of your diagnosis, can be short, or for some people can be agonizingly long. So time is always a factor in these discussions. I'll just put up those 3 images for the moment. And I talked already about the booklet being handed over. And it's great to see a lot of clinics now having stocks of our booklets. And I talked about notes. Now, we see on the bottom right-hand panel a typical notebook, a bit fancy maybe, but I've titled it My CLL Diary. And lots of people find that using a notebook to note all manner of things, their counts, their side effects, and questions they want to ask at a consultation. And some people prefer to be, as my dear departed mother used to say, in the .com era, use either their phone or a tablet to record all the information that would typically go down in a notebook. And I've shown you there the relationships. So the relationships at play, and because of my health and safety background, I love a fire triangle. And we have the patient and partner, we have the clinical nurse specialist, and we have the consultant. And that relationship between the patient and partner and all of the 3 groups here is two-way. There's information going both ways. And I'd like maybe Debs and David to explain to us the relationship between the consultant and the CNS and what conversations they have about the patient and partner's situation, and what information is key to be able to get from the patient and partner and to be able to use effectively. So, David, are we going to kick off with yourself, and let's talk about the initial consultation that you would have with a patient?
So people with chronic lymphocytic leukemia typically referred into our clinic by their general practitioner. And what we find is about 4/5 of people who come to meet us have gone for a blood test with their GP, often because they've been called in for a checkup or for monitoring of some pre-existing condition like blood pressure and diabetes. And the GP will have noticed that there's an increase in something called white blood cells. And white blood cells are things that everyone's got, and they help us fight infections. But sometimes there might be an increase in a particular type of white blood cell called a lymphocyte that is noted on the result. Very often what will happen is in the first instance, the blood test will be repeated maybe a week or 2 later, and the increase in white blood cells is still noted. At this point, the GP will often say to the person, check your blood and found this abnormality in the white blood cells. I'll just have a chat with hematology, which is us, the speciality that looks after people with CLL. And how that's done nowadays is there's sort of I'm not sure how best to describe it, a bit like a WhatsApp service between GPs and Dr. Freiger and myself. So the GP will send us an electronic message saying, could you look at the blood results on this person? What do you think? And we'll have a look and either give advice back or say, well, this is probably someone we need to be seeing in our clinic. And for somebody that may have CLL, we would appoint them into clinic. Sometimes, and the practice varies around the country, sometimes more specialist tests will be done before the person actually comes to see us. and this generally involves sending extra blood samples off to a specialist laboratory. So we all work in Hull or Hull in North Lincolnshire, and for us, our specialist laboratory is Leeds, about an hour away. So some blood will go off to Leeds, and then about a week or so later, we'll get a report back, and that may say that there's something called chronic lymphocytic leukemia or CLL present. And so the person concerned will come to our clinic. Usually they've been given a heads up by the GP that they found something in the blood, and we'll then the first question is generally always, do you know why you're here, and do you know why we've been asked to see you? Generally people know, but sometimes people unfortunately haven't been told, or there's been a communication breakdown, and they come to our clinic and aren't really quite sure why they're there. We'll then have a discussion about what's happened, and then go into a discussion about what's been found in the blood in chronic lymphocytic leukemia. A minority of people come to us though because they've actually gone to the GP and they said, look, I don't feel very well. I've got low energy, or I've noticed these lumps in my neck or under my arms. Again, then the GP will have done some blood tests, found some abnormalities suggested of CLL, and sent them through to us. And occasionally people will present directly to the hospital, so most commonly with maybe a chest infection, but again, sometimes with other unrelated problems. They've come in with appendicitis, say, or have been found to have an abnormality in the blood count, and advice is sought from us. So that's sort of the general route into our service, and how people would first come to meet us.
And who are they likely to see first? Would it be yourself, or would it be Andres, and when would Debs get involved?
So again, in Hull, they would generally meet either Andreas or myself or one of our other colleagues. So within our department, we've got about 7 or 8 consultants and about the similar number of junior doctors. So they could meet any of us. Some departments have people like Deborah doing nurse-led clinics. So very often, sometimes people might not necessarily meet a consultant or a doctor. They might meet a clinical nurse specialist, and sometimes they may meet a sort of a PA. So some departments have advanced practitioners who work under supervision, and then they'll be seen. The person's story or history will be taken, and then depending on the information available, we'll either discuss the diagnosis or say, well, I think we need more tests to be done. In terms of your question about how the three of us all work together, so we all work together. You'll have heard this before. We all work together as a team, and we all support each other, and we all have sort of different roles and responsibilities. And how an individual team works will vary sort of around the country from department to department.
How would you like to see, in an ideal world, a patient and their partner coming in to you to maximize the effectiveness of that early days, bunch of discussions you're going to have?
So generally, people will meet someone like myself. We'll have a 10, 15 minute, 30 minute, 60 minute chat, and then people will exit. And then they'll be supported. Really, sort of 90% of the support and the work comes from Deborah and her colleagues. So I think Deborah may have a view on this.
Yeah, so I think we do try to sort of be around to support the consultant when the patient is first come in, but more to just sort of be in the background at that consultation, to be able to then walk away with the patient to discuss what they've heard, how they feel. But we always do try to make sure, if we can speak to the patient, to advise them to fetch somebody with them, to make sure that they've got pens and papers, to make sure that they write any questions down that they can think of. So it all kind of streamlines that first initial meeting. So a lot of the questions, often if they're not written down, they forget to ask. But then obviously, as a CNS, it's our role to kind of pick up on that. So we'll then go off with the patient and spend some time with them, obviously going over what they've just heard, how they feel about that. Is there anything that they felt they should have asked and didn't? Is there anything, we haven't informed them about? And kind of just picking up pieces, because obviously we're all very aware that being given a new diagnosis like this for a lot of patients is quite stressful, and often, you know, they forget what they've been told. And yeah, so we do try to pick up those patients from that meeting and then go on to support them and find out what it is that they want from us, really, to make sure that we're covering everything.
And Andres, what would be your ideal timescale between that initial discussion and the follow-up one? Would it be driven by the holistic side, so that you can more or less repeat that information that Deb's just mentioned that is quite likely to be forgotten? Or would it be determined by some further tests you've carried out, and that will be the deciding factor as to when you'll see the patient next?
That scheduling the next appointment, I think the first will be patient need priority. So if there is any clinical concern based on the blood test or symptoms or any other concern that we need to act fairly quickly, then the next visit will be scheduled as soon as possible, as is directed by the clinical need. If there is no clinical concerns which require to expedite the appointment, I think that usual thinking time has to be offered to patients, to relatives, to families, and then I would say approximately maybe 2 to 4 weeks to digest all the informations, go through all the written leaflets we provided. Then there is obviously family dynamics, which that information is going through. Quite often patients got their own doctors, trusted doctors, or some doctor in family. They want to run this information through, and then to come back to us and rediscuss the situation. So very individualized approach, guided by patient need. If there's any urgency, that take priority. If just there's to communicate the information, then number of weeks will be required to process the information provided.
The next slide I'd like to bring up, just to prompt our discussion. Let's talk about accessibility. And on our website, all our information is available in a variety of languages. There is that button that I've just arrowed in, and you can get, albeit a Google Translate, but all the languages that are available. And in fact, we've had feedback from clinical nurse specialists that have told us that that facility was really, really useful in guiding patients who don't have English as a first language. And there's all sorts of other accessibility tools there, from dark screens, all of that. So we're on Zoom at the moment, and I know that during the pandemic and post-pandemic, there were some video consultations. I myself, because of the routine nature of my consultations, take part basically in a telephone conversation after having bloods, which monitors my situation regularly. But I'd also like to bring in other factors like hearing loss or sight impairment. If a patient has either early signs or advanced dementia and other comorbidities, and let's use those images and those words to prompt our discussion. Maybe back to you, David, at this stage, as to how you factor in. Do you do video consults?
So obviously after our first consultation, and they've met Andreas and myself, and we've imparted the diagnosis of CLL, and Deborah has come in and supported the consultation, and then more likely than not, Deborah or one of her colleagues will have got in touch with the person following the consultation, particularly if we've picked up either additional needs or need to talk again. But eventually we'll embark on a plan, and for the vast majority of persons with CLL we meet, the initial plan is careful monitoring. And the frequency and of the monitoring is determined a little bit by the nature of the CLL. Is it early stage? Is it sitting there absolutely stable and doing nothing, or is it moving forward? And again, where we are in Hull, we cover a large geographic area. So the nature of someone's follow-up is also partly determined by where they live and how easy is it for them to get to the centre. Around the country as well, again, how persons with CLL are followed up varies quite widely. So in some places, it's entirely done through hospitals. In other places, people are discharged back to general practitioners. In some places, it's done between hospital and primary care. And in other places, it's sort of led largely by the centre, supported by people like Deborah, either physically seeing or monitoring people in the community. So locally, we have a mixture of approaches. It's predominantly around either face-to-face consultations with someone like Andreas or myself. Deborah and her colleagues do a lot of telephone consultations. So a system will be arranged whereby the bloods are checked at a place near to where the person lives, and then a telephone consultation is held. We don't do a lot of video consultations locally because they sort of beget a whole new set of problems, which you'll be familiar with, John, around logging in, waiting in some virtual waiting room, losing your connection, and so on. And so I didn't find it. I found it difficult, more difficult than a telephone consultation. And so locally we've moved away from it, but plenty of places around the country still do video consultations, and that's fine. You have to adapt how you follow somebody up around their individual needs. So partly that's driven by, do they have CLL that's clearly going to sit there and do nothing for hopefully decades, or are they somebody that's going to head for treatment in the next year or two? And also you have to factor in, how easy can get to hospital. Is the car parking at the hospital? Is the public transport? There's, as you say, issues around hearing. So having a telephone consultation with somebody who's hard of hearing or has some sort of dementing type illness is very different. Not really related to this, but by way of an example. So I look after other conditions other than CLL, and one group of conditions I look after, there's a lot of teenagers. Trying to do a telephone consultation with a teenager is very, very difficult. So a lot of them just don't answer. A lot of them find telephone conversations difficult because of. So you have to judge how you deal with follow-up. And each place around the country, as I said, will have their own sort of system based around what their service can do and the sort of nature of their local population.
Deborah, David then mentioned that you do a lot of telephone consultations. So from your perspective, how do you maximize the efficiency of that? And it sounds a very sort of business term to use, but how do you get best results from a telephone conversation?
So yeah, we do a lot of CNS nurse-led telephone clinics, and they seem to work very well. As David said, we cover a huge geographical area, and a lot of our patients are unable to get to the clinics face-to-face appointments. And also the clinics are so busy, they don't want to come, they like the telephone. We've had a lot of time with these patients, so we can make sure that if patients are hard of hearing or partially sighted or have are not English speaking, we can try to arrange things to facilitate this. So we make sure that patients have got somebody with them at the time that we're going to ring. We make sure that all those things are set up. We have special telephones that can do three-way conversations and translators and all those sorts of things. So we can put all those sorts of things into place, to facilitate conversations that you would otherwise think that you couldn't have on the telephone. There are things we can put in place to make those happen. And I think it's just it's a really good way to sort of view a lot of people. They can get their bloods done locally, as David said. They're not having to travel, they're not having to spend money on petrol, they're not having to get relatives to take them. There's all sorts of complications with face-to-face, and they are also very time consuming for patients. A lot of our patients are still working, you know, they have working lives. They just want something quick, something easy. And as a lot of them are just on active monitoring, you know, it's just a case of really them making sure the bloods are done and just checking up, just that 5-minute conversation, checking everything's okay. Obviously, if there are any issues raised whatsoever, we would always fetch them straight back to clinic. But yeah, I think telephone clinic for a lot of patients works really well.
So we're really now moving from the initial diagnosis and the delivery of that bad news and moving in towards active monitoring. But in terms of the reassurance and the messaging that you would give a patient, how do you think that's best done? And any of the three of you, please just respond to that.
It's the approach I take is obviously that people are best to be as some people are worried and scared, and you know, and being told you've got a blood cancer is scary. But generally, you're best to be as well informed as possible about what's going on, so you can understand your condition and what may or may not happened. And generally, sort of knowledge is power. So if you understand things as fully as possible, that helps you in a way take control. If you fully understand what you have, it enables you in some way to have a degree of control. And I always try and be clear with people that someone's walked into the clinic room and met Debs and myself and had a conversation, but when you leave the room, you're still the same person. You know, you're not, you haven't suddenly changed because you've met somebody like me and been told you have a blood cancer, told CLL. You're still the same person. You're not a CLL patient. You're not defined by your disease or your illness. You're a person who is living your life doing whatever it is, and you also have this condition CLL, which amounts to a chronic illness in the same way that maybe blood pressure is or diabetes. So I'm very keen on people being as informed as possible, or as informed as they want to be. But we try and enable it such that people aren't defined by their illness. They're not you're not a CLL person or any, a COPD person or a diabetes person. You're a person that happens to have these health problems.